Ever felt like you're just drowning in health information? You try to understand something, maybe something your doctor said, or you're just curious, and suddenly it's just a mountain of jargon.
Yeah, and conflicting opinions too. It can be really overwhelming.
Exactly. And that's why we're here. Welcome to the deep dive. We try to cut through all that noise.
Bring you the essential stuff. And today, we're diving into how doctors figure out what's going on with the veins in your lower legs.
Yeah.
Specifically, conditions called chronic venous disorders, or CVD.
Right. And we're basing this on some solid material chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. We're looking at Venous Physiologic Assessment.
Which basically means going beyond just, looking at pictures of the veins. It's about understanding how well they're actually working, how the blood is flowing.
Precisely. It's the function we're interested in today. So if you've ever been curious about those leg vein tests, what they measure, what the results actually mean for your health, well, this deep dive is for you.
We're going to unpack some key techniques. Things like measuring vein pressure when you walk. That's ambulatory venous pressure.
CVP, yeah.
And various types of plethysmography.
Yeah.
We'll break down what each test tells us about how your veins are doing that job of getting blood back to the heart.
Okay, let's jump in. Ambulatory venous pressure, AVP. This isn't exactly a brand new idea, is it?
Oh, not at all. People were starting to measure this stuff way back in the 1930s. Later on, researchers like Pollack and Wood, they really standardized the method.
And what did they find?
Well, a key thing was how much faulty vein valves affect pressure down in the ankle. Those little one-way gates in the veins.
Right. They're supposed to stop blood from falling back down.
Exactly. And if they're leaky, it causes pressure problems.
Yeah.
They also talked about something called the unicameral model back then.
Unicameral, one chamber.
Yeah, sort of thinking of the lower leg as one big compartment. It helps show how your calf muscles, when you walk and contract them, act like a pump.
Ah, the calf muscle pump. I've heard of that.
Yeah, right. It squeezes blood up through both the deep veins and the superficial ones. And that pumping action causes the pressure below the knee to drop. They called that drop calf diastole.
Okay. Like squeezing a tube of toothpaste, maybe?
That's a pretty good analogy, yeah.
So how do they actually measure AVP? It sounds a bit involved, maybe a little invasive.
Well, the standard way does involve a small needle or catheter. They usually put it into a vein on the top of your foot, the dorsal foot vein.
Okay. While you're resting.
You start resting, standing still to get a baseline pressure. Then you do about 10 tiptoe exercises, heel raises.
Right.
And they monitor the pressure the whole time. The lowest point it reaches during or after the exercise, that's your AVP.
The ambulatory venous pressure. Okay.
And they also measure how long it takes for that pressure to creep back up towards the baseline level. That's the calf diastole, or sometimes called the venous refill time.
So the lowest pressure and how fast it refills, what do those numbers tell the doctors?
So a normal result is a pretty significant pressure drop, usually like 50% or more from your standing pressure. And the refill time, the calf diastole, should be reasonably long, say 20 seconds or more.
Okay, so low pressure during exercise, slow refill. That's good?
That's good. Now, if you have problems with the valves, leaky valves causing backward flow, what we call reflux,
Reflux, right.
that refill time gets much shorter. Blood flows back down too quickly.
Makes sense. What about blockages? Obstructions?
Obstructions can actually make the pressure increase during exercise above your resting pressure. And sometimes you see a mix, maybe higher pressure and a fast refill.
Complicated.
It can be. And interestingly, problems in the deep veins usually cause higher AVP readings than problems just in the superficial veins. The really high pressures are often seen when you have both deep valve failure and a blockage higher up, like in the iliofemoral vein.
So quick refill often means leaky valves. High pressure often means a blockage. That's a key takeaway.
Generally, yes, though it's an overall measure.
Right. And then there was this other model mentioned, the polycameral model. Sounds fancier.
A recent idea, yeah. Instead of one big compartment, it thinks of the leg having multiple interconnected compartments, like the deep veins, the superficial veins lower down, the veins in the foot. They're linked, but maybe not always at the exact same pressure.
Uh-huh.
And studies have actually shown that the pressure measured in, say, the great saphenous vein, that's a major superficial vein, isn't always the same as the pressure in that foot vein where they typically measure AVP.
So why does that matter? What's the implication?
Well, it might explain something puzzling. Sometimes you see patients with really bad venous ulcers, a serious sign of CVD, but their AVP measured in the foot looks surprisingly normal.
Ah, because the foot vein pressure might not reflect the higher pressure happening elsewhere, closer to the ulcer.
Exactly. It suggests that just measuring that one spot might not always capture the full hemodynamic picture of the whole leg.
That's a really critical point. One measurement might not be the whole story. They also mentioned using a tourniquet sometimes during the AVP tests.
Right. They can put a tourniquet around the leg. What that does is temporarily block off the flow in the superficial veins near the surface.
Okay.
So if you do that, and then the AVP and the refill time suddenly look normal, well, that suggests the main problem is probably in those superficial veins, superficial incompetence, we call it.
And if the numbers stay abnormal, even with the tourniquet.
Then it points more towards the problem being in the deep vein system.
Clever, a way to isolate the issue. But it sounds like AVP, even with the tourniquet trick, still has limits.
It definitely does. It gives a good overall sense of the leg's hemodynamics, but it can't really pinpoint the exact location of a problem within the deep system or the superficial system.
And you said it can't easily distinguish between a blockage and reflux either.
Not definitively on its own, no. And of course, the fact that you need that needle in the foot, well, patients often prefer less invasive options if possible.
Absolutely. Nobody volunteers for extra needles. So that brings us to plethysmography. That's a mouthful. What's the basic idea there?
Okay, so plethysmography isn't one single test. It's a group of techniques, but they all work on the same basic principle: measuring changes in the volume of the limb.
Volume changes due to blood flow.
Exactly. As blood flows in and out, the leg volume changes slightly. By measuring that, you can assess both obstruction, is blood having trouble getting out, and reflux, is blood flowing back in when it shouldn't.
Okay, measuring volume changes. And you mentioned they prefer using a blood pressure cuff for this.
Yeah, for many techniques. Instead of relying on the patient doing specific movements perfectly, they often use a cuff to temporarily stop blood flow, like inflating a blood pressure cuff on the thigh. It tends to give more consistent, reproducible results.
Right. Takes some of the variability out. So it's like tracking how much the leg swells and shrinks with blood flow changes.
That's a good way to put it.
Okay, there were several types mentioned. Let's start with strain gauge plethysmography, SPG.
Right, SPG. This uses a little flexible mercury-filled tube, like a tiny rubber band, wrapped around the calf.
Mercury.
Yeah, or sometimes other materials now. But the principle is, as the calf swells with blood, the tube stretches, and its electrical resistance changes. That change is measured.
And what was this used for?
Historically, it was actually used quite a bit to look for blood clots, DVTs, especially clots higher up, like in the femoral or popliteal veins behind the knee.
Was it good at that?
It was reasonably okay for those bigger, higher veins,
Huh.
but less reliable for clots further down in the calf. And nowadays, duplex ultrasound is just much better for diagnosing DVTs, so SPG isn't really used for that much anymore.
Ultrasound took over.
Pretty much. Though there's some renewed interest in using computerized SPG to look at something called venous claudication.
What's that?
It's a cramping pain in the leg when you exercise, caused by poor venous outflow, basically blood not draining properly during activity. So SPG might still have a niche role there.
Okay, so SPG, mostly historical for clots, maybe some niche use now. What about impedance plethysmography, IPG?
IPG works differently. It measures changes in electrical impedance or resistance in the calf.
How?
They place electrodes on the leg. One sends a tiny electrical current through the tissue, and others measure how much resistance that current encounters. Blood is a good conductor, so as the blood volume of the leg changes, the impedance changes.
And this was also used for clots.
Yes, similar story to SPG. It was used for DVT diagnosis back in the day, but again, ultrasound is now the standard.
So another one largely replaced.
For DVT, yes. But like SPG, there's some new research exploring if modern IPG technology could be useful for other things, maybe monitoring venous insufficiency or even estimating central venous pressure non-invasively. But that's still pretty experimental, really.
Interesting how these older ideas sometimes get revisited with new tech. Okay, next up, photoplethysmography, PPG. Sounds like light is involved.
You got it. Photo means light. PPG uses little sensors, often placed on the skin, maybe on the ankle or lower leg.
What do they do?
They shine infrared light into the skin and measure how much light is reflected back or absorbed. Blood, specifically the hemoglobin in red blood cells, absorbs this light. So, as the amount of blood in the tiny capillaries just under the sensor changes, the amount of light reflected back changes.
Ah, so it tracks blood volume changes right there in the skin.
Exactly. Tiny changes in those superficial vessels. PPG was actually first introduced as a non-invasive way to estimate AVP, particularly that refill time.
As an alternative to the needle.
Kind of. And studies show it's pretty sensitive for detecting reflux, that backward flow. It's good at picking it up if it's there.
Well, there's always a but.
But its specificity isn't as great, meaning it might sometimes suggest reflux is present when it's not, or overestimate its severity.
Why is that?
It can be affected by other things, like if the leg is swollen for other reasons, or if there are lots of prominent varicose veins, or even if there's underlying artery disease. Skin temperature, room lighting, patient position. These can all influence the reading too.
So, sensitive for picking up reflux, but maybe not as precise, and can be thrown off by other factors.
That's a fair summary. But the really exciting thing with PPG is wearable technology.
Oh, yeah.
Fitness trackers, smartwatches. Many use PPG sensors for heart rate. And now they're exploring using similar tech for things like cuffless blood pressure, monitoring heart rhythms.
And potentially venous issues, too.
That's the hope. There's a lot of potential for these wearable PPG sensors to give us new ways to monitor venous function over time outside of the lab. Still early days for venous applications, but promising.
Wearable tech for vein health. That's definitely something to watch. Okay, quickly, foot volume plethysmography, FPG.
Yeah, FPG is more common in Europe.
Yeah.
As the name suggests, it directly measures volume changes in the foot. It's used to assess vein function specifically below the ankle. A bit more of a specialized tool, not as widely used everywhere.
Got it. Specialized for the foot. Which brings us to the last one, air plethysmography, APG. This seemed like a big one in the material.
It is. APG is often seen as maybe the most comprehensive of the plethysmography techniques. It can quantify reflux, obstruction, and that all-important calf muscle pump function, all in one test.
Okay, comprehensive. How does it work? Is it that cuff again?
It is, but it's a specific type of cuff. It's usually a long, air-filled cuff made of polyvinyl chloride, PVC, that wraps around the leg from the knee down to the ankle.
The whole lower leg.
Right. And it's inflated to a very low pressure, just enough to sense volume changes.
And what does the patient do?
First, you lie down with your leg elevated for a bit, let the veins empty out, let the leg adjust to room temp.
Okay.
Then you stand up, but put your weight on the other leg, letting the leg being tested hang slightly. This allows the veins to fill passively, just due to gravity.
And the cuff measures that filling.
Exactly. It measures the increase in leg volume as the veins fill. The maximum volume reached when you're standing like that is called the venous volume, or VV.
Total volume the veins hold.
Basically, yes. They also measure the time it takes to fill up to 90% of that volume. That's the venous filling time 90, or VFT 90.
Okay, VV and VFT 90.
And from those two, they calculate the venous filling index, VFI. You get it by dividing the volume filled, 90% of VV, by the time it took VFT 90.
So VFI is like the speed of filling.
Essentially, yes. It's the average rate of filling when you stand. A higher VFI generally suggests more reflex blood flowing back down and filling the leg faster than it should.
Okay, so VFI gives us a handle on reflex. What about the calf pump?
Right. That's the next step. After the leg is full, you stand normally on both feet. Then you do one single strong tiptoe exercise, a heel raise.
Just one.
Just one initially. The cuff measures how much volume is squeezed out of the calf by that single muscle contraction. That's the ejection volume, EV.
How much blood the pump pushes out in one go.
Exactly. Then, after letting the leg refill, you do a series of 10 tiptoe exercises, one after the other.
10 in a row.
Yep. And the volume that's still left in the leg veins after those 10 pumps, that's the residual volume, or RV.
What's left behind after pumping?
Okay. And from these, they calculate two key things. The ejection fraction, EF, is the ejection volume from the single pump divided by the total venous volume. It tells you what percentage of the blood the pump squeezed out in that one contraction.
Okay, efficiency of one pump.
And the other is the residual volume fraction, RVF. That's the residual volume left after 10 pumps divided by the venous volume. It tells you what percentage of blood is left behind after repeated pumping.
So RVF is about how well the leg empties with sustained pumping?
Precisely. And a normal RVF should be low, usually less than 35%. A high RVF means the pump isn't emptying the leg effectively.
And how important are EF and RVF?
Very important. They're really good measures of calf muscle pump function. And interestingly, RVF correlates pretty well with that invasive AVP measurement we talked about earlier.
Oh, so APG gives a non-invasive way to estimate something similar to AVP.
In terms of reflecting the overall hemodynamic consequence of pump function and reflux, yes, the RVF gives a good indication. And studies have shown EF and RVF are strongly linked to the severity of venous disease.
How so?
Well, for example, a really good ejection fraction, say above 60%, seems protective. Even if someone has reflux, they're less likely to get ulcers if their pump works well. But a very low EF, like below 40%, is often seen in legs that do have ulcers, even if the reflux isn't that severe.
Wow. So the pump function itself is hugely critical in preventing the worst outcomes.
Absolutely vital. It highlights why exercise and maintaining calf muscle strength is so important for vein health.
Makes sense. Now, you also mentioned APG can help tell apart problems in the deep versus superficial veins, like the tourniquet trick with AVP.
Sort of, yeah. They can repeat the whole APG test, but this time with a separate cuff placed high on the thigh and inflated quite tightly.
To block off the superficial veins.
Exactly. So the measurements then primarily reflect what's happening in the deep system. They can also use that thigh cuff to measure outflow. After letting the leg fill and inflating the thigh cuff, they suddenly release the cup pressure.
And see how quickly the blood drains out.
Right. They measure how much volume leaves the leg very quickly, usually in the first second. That's the venous outflow, VO.
Fast drainage is good, presumably?
Yes. And they calculate the outflow fraction, OF1. That's the outflow in the first second, divided by the total venous volume. A low OF1, like below 28%, strongly suggests a significant blockage or obstruction in the deep veins, hindering outflow.
So APG seems to cover a lot. Reflux, pump function, outflow, and differentiating deep versus superficial. Pretty comprehensive.
It really is quite informative.
There was also something called the Venous Drainage Index, VDI.
Yes, VDI. That's a slightly newer parameter you can get from APG. It basically measures how much the calf volume decreases when you go from standing with the leg down to elevating the leg.
So how well it drains just with gravity.
Kind of, yeah. And research suggests that VDI correlates with the degree of venous obstruction. So it's another non-invasive clue about potential blockages.
And that other index, VFI, the filling index, does that relate to how bad the venous disease is?
Definitely.
Oh.
Lots of studies show a strong link between the VFI value and a clinical severity of chronic venous disease using that standard CEAP classification system doctors use.
Higher VFI means more severe disease.
Generally, yes. Faster filling often means more significant reflux and pooling. And interestingly, VFI values going down, especially below 2 millionels per second, have been linked to actual improvement or resolution of the disease after treatment works well.
So you can potentially track treatment success with VFI. Okay,
Right.
APG sounds powerful, but limitations. There must be some.
Of course, like any test. Patient mobility is a big one. If someone can't stand easily or can't do those tiptoe exercises properly.
That messes up the pump measurements.
Right. Or if they have severe arthritis or other musculoskeletal problems. Open venous ulcers can also make putting the cuff on difficult or painful.
What about just very large or very small calves?
That can sometimes be an issue for cuff fit, yeah. And like AVP, while APG tells you if there's reflux or obstruction or a poor pump function, it doesn't pinpoint the exact anatomical location of the leaky valve or the blockage within the deep or superficial system. You usually need ultrasound for that level of detail.
So it tells you what's wrong functionally, but not precisely where anatomically.
Good way to put it. And it still can't always definitively separate obstruction from reflux on its own. But the big advantages are that it's non-invasive, generally well tolerated, and you can repeat it easily to track changes over time. It gives valuable hemodynamic information that really complements the anatomy you see on ultrasound.
It really sounds like these different tests, AVP and the various plethysmographies, paint different parts of the picture.
Yeah.
They overlap, but also offer unique insights.
That's exactly right. And generally, the different plethysmography methods tend to give reasonably consistent information. Studies comparing SPG, IPG, and APG usually find decent agreement. There was one interesting study mentioned looking at patients who had stents put in their veins to open up blockages.
Did APG show improvement?
Yes, on average, they saw statistically significant improvements in things like the ejection volume and the residual volume fraction after stenting, which makes sense. Less blockage should improve pump efficiency and emptying.
But I sense another but.
Well, the study also noted that while the average improvement was significant, the actual amount of change varied quite a lot from person to person, and the average changes weren't massive. So it's hard to take those group results and say, okay, this specific patient will definitely get X amount of improvement based on their pre-stent APG.
Right. Group averages don't always predict individual outcomes perfectly. That makes sense. Okay, let's talk reliability. How dependable are these venous tests in general? Sounds like things can affect them.
Absolutely. Reliability can be a challenge. We mentioned patient factors already, how well they can do the maneuvers. But even things like the room temperature can affect vein function and test results.
Really? Temperature matters.
Oh, yes. Veins constrict in the cold and dilate in the heat. So keeping the testing room at a consistent, comfortable temperature is pretty important for comparable results.
Okay. What else?
Well, just standardizing the whole testing procedure is key. Making sure everyone does the exercises the same way, rests for the same amount of time, etc. It can be tricky to get perfect consistency in a busy vascular lab.
And you mentioned variability, like test to test.
Yeah, some studies have reported a degree of variability if you repeat the test on the same person, and maybe even differences between a test done in the morning versus the afternoon. Leg swelling can change throughout the day, for instance.
Morning versus afternoon tests could differ. That's important. So what's the advice then to get the most reliable results?
Basically, standardize everything possible, keep the room temperature steady, repeat tests if the results seem borderline or unexpected to confirm, and maybe be aware of the time of day, especially if you're comparing tests done on different days.
Consistency is key.
And it's worth remembering, these tests aren't just for legs. You can adapt plethysmography and pressure measurements for evaluating venous problems in the arms, the upper extremities too.
Good point. So wrapping this part up, what's the big picture clinical value here? Why do these physiologic tests matter alongside just looking at the veins with ultrasound?
Well, they're really valuable for a few key reasons. One, they can help track if someone's venous hemodynamics are getting worse over time, even before symptoms change much.
Catching deterioration early.
Right. And maybe even more importantly, they can objectively measure if a treatment is actually working. Did compression therapy improve pump function? Did that vein procedure reduce reflux and lower the RVF? Plethysmography can help answer that.
Quantifying treatment benefit.
Exactly. And sometimes APG in particular can pick up significant calf muscle pump failure, even when the ultrasound maybe doesn't show major valve problems or blockages. It highlights that the pump itself can be a primary issue.
So it adds a whole functional dimension.
Precisely. It complements the clinical picture your doctor gets from examining you and talking to you, and it complements the anatomical map provided by duplex ultrasound. Putting all three together, clinical, anatomical, and physiological, gives the most complete understanding of chronic venous disease.
Okay, so let's try to summarize our deep dive today. It seems really clear that understanding vein problems in the legs, these chronic venous disorders, is about much more than just looking at them.
Definitely. The anatomy from an ultrasound is crucial, but these physiologic tests, AVP, and especially the different kinds of plethysmography like APG, they tell us about the function. How well is the blood actually moving?
Right. We talked about AVP measuring pressure during walking, giving insights into valve competence and overall pressure dynamics, though it's invasive.
And then plethysmography, measuring volume changes. We saw PPG is good, non-invasively for spotting reflux, especially with new wearable potential.
Yeah, the wearables are exciting.
And APG seems like the most comprehensive, quantifying reflux with VFI, obstruction with outflow measures, and that critical calf pump function with EF and RVF.
Giving that whole hemodynamic picture.
Exactly. Information you just can't get from looking at static images alone.
And hopefully for you listening, this dive has maybe demystified some of those tests. It gives you a framework, right, for understanding how doctors are trying to figure out not just what your veins look like, but how well they're actually working deep inside your legs.
It really is about understanding those complex dynamics of blood flow.
So on that note, here's something to chew on. We've talked about how complex venous function is and all these different ways to measure aspects of it. What do you think is the biggest hurdle right now in really getting a handle on chronic venous disorders and treating them effectively? Is it the complexity itself, the limits of our tests, or maybe just how different it can be from one person to the next?
That's a great question to ponder. There's still a lot to learn.
Indeed. Keep exploring, keep asking questions. Thanks for joining us for this deep dive.